Today we will be starting a new topic, that is Introduction to Anemia in Pediatrics. So to begin with, let's begin with what is the process of haematopoiesis. What happens in haematopoiesis? The physiology part. So what happens in haematopoiesis is there is something called as hematopoietic stem cells in every child. Okay, that one will start forming something called as CFU, that is colony forming units. CFU, colony forming units. These colony forming units will then get divided into committed stem cells, that is different types of stem cells. We can actually call them as myeloid precursors. They are divided into two groups. The one group that will form erythrocytes, and the other group that will form your granulocytes. So granulocytic group and erythrocytic group. The myeloid group will divide it into erythropoietic group and your granulocytic group. Then these further divided into their respective categories, that is the erythrocytic group, that is CFU, colony forming units of erythrocytes, will form into reticulocytes, then forming red blood cells, whereas the colony forming units of platelets, that is megakaryocytes, form into megakaryocytes, leading to formation of platelets. In the same manner, the granulocytic CFU will form the CFU for each of them, that is for monocytes, eosinophils, neutrophils and basophils, respectively forming the respective cells, that is monocytes, neutrophils, eosinophils and basophils. Now here the hematopoietic cells will also give rise to bone marrow lymphocyte precursor cells. Okay, this bone marrow lymphocytic precursor cells will give rise to three types of cells actually. The two main which we know, that is B and T lymphocytes respectively, and whereas the another one is natural killer cells. So in short, this is what is the hematopoietic cycle. Okay, the hematopoietic stem cells giving rise to colony forming units, then colony forming units divides into committed stem cells, that is group of erythropoietic colony forming units and granulocytic colony forming units. The erythrocyte colony forming units forms red blood cells as well as platelets, whereas the granulocytes forms monocytes, neutrophils, eosinophils and basophils. Here the bone marrow lymphocyte precursor will give rise to the B cells and T cells. This is what is the basic physiology which we must know before beginning any hematological disorders. Now let's coming to the topic. So what is the definition of anemia? Okay, anemia is defined as the decrease of below normal limit, that is in case of pediatrics, or here we have to tell it is less than 2 standard deviation. Okay, if anemia is defined as hemoglobin level in the blood less than 2 standard deviation for a particular age and sex, that is what is given in this definition. See, below the reference level of age and sex of a particular individual. That is what is the actual definition of anemia. We can also define anemia as something called as reduction in the total circulating red masses below the normal limits. The normal limits will come for the particular age groups in the subsequent discussion of the class. And now we can functionally also define anemia. What is the functional definition of anemia? Simple. What is the function of blood? That is transportation of oxygen. That is, you can tell as decrease in the oxygen carrying capacity of the blood leading to tissue hypoxia is the functional definition of anemia. Now anemia can be absolute anemia and something called as relative anemia. Absolute anemia means that is the absolute decrease in the red cell mass, RBCs, whereas relative means it is associated with higher plasma volume. Okay, generally the anemia is always absolute anemia, that is decrease in the red cell mass. Why this high plasma volume happens and all, we will discuss in the further more slides. So this is what is called as the actual definition of anemia. There you can define it in 3 different ways. Okay, the actual definition is less than 2 standard deviation of a hemoglobin for a particular age and sex. Now coming to the physiological adaptations that happens during anemia in a child. What happens during what happens in the physiology actually? So what happens initially is, for anemia to develop, what happens is, first enhanced release of O2 from hemoglobin happens. initially. Then there will be increased blood flow to the tissues. When these both mechanisms fail, then on the body will develop anemia. Till that, these are the compensatory mechanisms that the body will involve. That is enhanced release of oxygen from hemoglobin and increased blood flow to the tissue. This is the physiological compensatory mechanism. If the mechanism fails, it leads to anemia. Now, what are the physiological adaptations that happen after the anemia develops? So, what is anemia? It is nothing but decreased oxygen carrying capacity of the blood functionally. So what will happen now? See, if the oxygen capacity is reduced, one thing we have to do is we have to increase the cardiac output. That is, more blood should be pumped into the organs. That is increased cardiac output. That is the one of the physiological adaptations that will happen. Next, what will happen? There will be increase in the volume of the plasma, and plus along with that there will be redistribution of the blood. What happens here? The redistribution of the blood means the blood from the peripheries is withdrawn and is supplied to the central main organs, that is your brain, heart and other functioning organs from the skin periphery. That's why in anemia redistribution of blood happens and there will be increase in the plasma. These are the physiological adaptations that generally happen in the body of a child. Now, to begin with, let's first classify anemia morphologically. So, morphologically, anemia is classified into microcytic anemia, normocytic normochromic anemia, and macrocytic anemia. The further explanation of each of these will happen when we discuss the subsequent diseases. It is just the classification which we have to know now. What happens in microcytic means the size of the RBC is less, we have to consider. In normocytic, the size is normal, whereas in macrocytic, the size is large. That is what the name indicates. Now, what is this hypochromic? This is the central pallor of the RBCs. If the central pallor here, this one, if the central pallor is more than 1/3, you can call it as hypochromic. In normochromic, the pallor will be normal, whereas in macrocytic also the pallor is normal. Okay. Now, why in microcytic and hypochromic anemia, the red cell indices, that is mean corpuscular volume, mean corpuscular hemoglobin concentration and all will vary according to the particular classification. That is, for microcytic, they will be decreased. In normocytic, they will be increased, whereas in macrocytic, the MCV will be generally increased. What are these red cell indices? We'll discuss about it now. Now, to begin with, what is mean corpuscular volume, MCV? It is nothing but it is the indicative of average volume of RBC and is expressed in femtometers. It is nothing but the volume of RBC present in the blood. That is your mean corpuscular volume. Now coming to MCH, that is mean corpuscular hemoglobin. It indicates the weight of the hemoglobin, that is amount of hemoglobin present in the body. Now coming to what is called as mean corpuscular hemoglobin concentration. Okay, this one, mean corpuscular hemoglobin concentration, MCH. This denotes the average concentration of hemoglobin in the RBC taking volume into account. Here we take a particular volume of RBC and we calculate the concentration of hemoglobin in that particular RBC. It is generally expressed in grams per deciliter. Here, this MCV, that is the amount of RBCs, is generally increased in case of macrocytic anemia, whereas it is normal in normocytic and it is decreased in microcytic anemia. MCH, that is the amount of hemoglobin concentration in a particular volume of RBCs, is generally reduced in microcytic and hypochromic anemia. It is normal in both the cases of normocytic and hypochromic. The best example for microcytic hypochromic anemia is your iron deficiency anemia. Okay, the normocytic normochromic anemia is generally seen in case of blood loss or hemorrhage. Macrocytic anemia, the best example is your vitamin B12 and folic acid deficiency. So this is in short about the morphological classification of anemia. Now let's see what are the clinical features that a child comes to you. Okay, if the child is having something called as anemia, or if the child is suffering from chronic stages of or few stages of anemia. So let's begin the clinical features. What are the clinical features generally? These are the broad clinical features. Generally, the child comes with tiredness, lassitude. What is lassitude? Lassitude is nothing but loss of energy. That is, the child doesn't have much of energy, and easy fatigability. The child will be tired. Weakness will be there in the child. That is also a symptom. Weakness of muscular system. Okay, these are the broad clinical features, general features that a child comes with. Okay, there might be other features like dyspnea. Okay, this happens generally after exertion. Okay, in mild anemia. In severe anemia, dyspnea may be present at rest also. Then you can see tachycardia also and palpitations in the child. Okay, so there will be a most important sign in these childs. What are the signs? These are the symptoms, which we talked right now. Now, what is the most important sign? That is the pallor. Child will be having pallor here. Okay, pallor. This pallor can be seen in nail beds. Okay, oral mucous membrane and your conjunctiva. Okay, these are the sites where the pallor will be visible in the child. Okay, there is some other signs like haemic murmurs. Okay, what is this? This is nothing but a mid-systolic murmur. Okay, what does this show? This shows there is increased velocity of the blood. That is, the cardiac output has increased to compensate for the anemia. That is what this haemic murmur will show. This is generally heard in the pulmonary area. Okay, these are the important points regarding to the haemic murmur. This is also a sign which will be present. The child may also present with some neurologic nervous system involvement or nervous system symptoms. Sorry, to tell properly, it is the symptoms relating to nervous system. That is symptoms like dizziness, headache. Okay, the child may have episodes of fainting. He might have tinnitus also, lack of concentration. Okay. So this is what are the general symptoms or clinical features of a child that will present to you. Now let's see small ECG findings, like the general ECG findings present in a child having anemia. These are, it will have normal QRS waves. Okay, there will be depression of the ST segments, okay, in the ECG. Okay, there might be flattening or inversion of the T waves. Okay, normal QRS waves, depression of ST segments, flattening or inversion of T waves is the general ECG findings in a child having anemia. Okay, so now we will coming to approach of diagnosis. That is, if a child comes to you, what is your approach, okay, to determine what type of anemia or what is happening in the child. Okay, to begin, before the diagnosis, the approach of diagnosis, we will see something called as what are the different types of hemoglobin in a newborn. Different types of hemoglobin. Okay, the different types of hemoglobin are 3 types. Okay, the first one is embryonic hemoglobin. Next one is your fetal hemoglobin, and the adult hemoglobin, which we all know. Okay, there are different types of embryonic hemoglobin. Okay, that is hemoglobin grower 1, hemoglobin grower 2, okay, and Portland hemoglobin. These are the different types of embryonic hemoglobins. Okay, fetal hemoglobin, that we all know, that is HbF. It is alpha 2 gamma 2. Adult hemoglobin, that is HPA, we all know that it is alpha 2 beta 2, and there is something called as adult hemoglobin 2. This is alpha 2 delta 2. Okay, these are the different types of hemoglobins present. Okay, what are the major sites of haematopoiesis, okay, in the child or in the duration of infancy? Okay, major sites of haematopoiesis. So it starts in the yolk sac haematopoiesis at around third week. Okay, third week until 10th to 12th week. Then you have haematopoiesis in the liver that starts around 6th to 8th week. Okay, it will continue till second trimester. Then you have the bone marrow. Okay, it will start after second trimester and will continue. Okay, and now we will also see a basic physiological fact, that is what is the normal lifespan of RBCs. Okay, normal lifespan of RBCs in a term neonat is 90 days. Preterm neonat it's around 40 to 60 days. Okay, and then in other children and adults it will be 120 days, as we all know that. Okay, this is the general physiological fact regarding to that. So now we will see the approach to diagnosis. So first, in the history, what we have to do, we have to take the proper obstetric history of the mother. Okay, proper obstetric history of the mother must be taken. See, the mother might have anemia, okay, or she might have any torch infections or anything else, or there might be some vascular diseases. Okay, we have to take the history of blood groups of both mother and fetus to find out ABO incompatibility and RH isomerization. Okay, this might also lead to anemia. There you have to also determine ask the family history about G6PD deficiency in the family or any other hemolytic disorders in the family. If the family is having any hemolytic disorder, there will be family history of hemolytic disorders 1. Okay, there will be also history of splenomegaly in the family of the other siblings. Splenomegaly will be there, and there will be gallstones in the family. Okay, or there might be removal of the gallstone surgery also might have taken place in the family. So these history will show us or lead us towards the diagnosis of hemolytic anemia in a child. Okay, we also have to take the proper history of diet. Okay, the type of diet, what is the type of milk the child is being, if the child is on cow milk, goat milk, or if the child is taking proper mother's milk. All this history must be taken in the history. Now see, generally the nutritional anemias, okay, nutritional anemias present around 6 months to 2 years of age. Okay, why? Because this is the period after 6 months we start weaning. That is complementary feedings to the child. After exclusive breastfeeding for 6 months, we start complementary feedings for the child. So it is this period where the child might lack nutrition and end up in having nutritional anemias. Okay, then if the child is if the family is vegetarian diet following, and if they are giving goat milk to the child, there are chances of development of megaloblastic anemia. Okay, there are chances of development of megaloblastic anemia. Around 4 to 6 months, all the thalassemia patients present to you. Okay, generally the thalassemia patients will present to you around at 4 to 6 months. Okay, 70% of thalassemia patients have symptoms by 1 year of age. Okay, have symptoms by 1 year of age. There is something called as pure red cell anemia. Pure red cell anemia, that is also called as diamond black fan anemia. This generally presents around 3 months. Okay, generally presents on 3 months. Here the child has decreased reticulocyte count. Okay, in pure red cell anemia, the child generally has decreased red cell count. Okay, we also have, as I already told, we should also ask about the family history of any genetic disorders like hemolytic anemias or G6PD deficiencies or jaundice in the previous newborn child and all. Then we have to do proper examination. Examination findings for anemia we will discuss later on the subsequent classes, where we will discuss each anemia separately. There might be signs of splenomegaly, lymphadenopathy, hepatosplenomegaly. Okay, we all should find these findings. Based on the findings, we can come to a conclusion. Now, let's see. We know that reticulocyte is very important now. So, before coming to reticulocyte, we will also study something called as laboratory investigations of the child. Okay, laboratory investigations of the child. What are the investigations that you will ask the child to get done so that it will help you in finding out a diagnosis? First one, as usual, we all know, complete hemogram. Okay, what does this shows? See, complete hemogram, okay, will show us which cell lineage is involved, whether it is just anemia or any other cell lineage are involved, so we can think about malignancy and all. That is, the lineage of cells involved will be shown in complete hemogram. Okay, then what we do is your red cell indices, which I explained in the morphological classification. Based on the red cell indices, we again divide into microcytic, normocytic and macrocytic anemia. Okay, this is what we could do. Then we also give RDW, that is red cell distribution. So what is the inference of this one? See, if the red cell distribution is decreased, then we know that all the RBCs are small in size, okay, or normal or uniform in size. If it is increased, then we know that all the RBCs vary in size. All the RBCs varies in size. Okay, then we give something called as, we'll also check the reticulocyte count. Based on it, we have certain classification of flowcharts which we'll discuss in the following subsequent slides. Okay, so what are the situations where you get decreased reticulocyte count? Are congestive or acquired aplastic or hypoplastic anemia. These, here we have to just memorize this so that in subsequent classes we can correlate the finding. This is just the approach, so that if a child comes to you, you can come to a proper conclusion of what type of anemia the child is suffering. That is what is the main aim of discussion of this class. Okay, it is also seen in pure red cell aplasia or infections due to parvovirus, okay, or as bone marrow infiltrations with malignancy, that is leukemia and all. In such cases, you have low reticulocyte count. Where is the reticulocyte high? Here, in such cases of hemolysis, the reticulocyte is very high, or in case of hemorrhages or splenic sequestration. See, one logic here is, when is the reticulocyte count high? See, when there is rapid destruction of the RBCs, the bone marrow production increases and it releases immature RBCs, that is reticulocytes, into the blood count. So there will be increased reticulocyte count. So obviously in hemolysis, in hemorrhages, in splenic sequestration, there will be lysis of RBCs. Okay, or in recovery of B12 and folic acid or any other iron deficiency anemia, or in sepsis, there will be increased hemolysis of RBCs, leading to increased production of RBCs, so that the bone marrow releases immature blood cells, that is reticulocytes, in the blood. So now we will come to the approach to diagnosis, that is the flow charts which we have to learn. Now there are some 3 flow charts which we have to know here. See, let's begin with, we also do the investigation of peripheral smear. Okay, along with those blood investigations, we also do peripheral smears, where we see the different types of RBCs. there may be schizocytes, polychromasia, specific red cell morphology, or there might be any parasites in the red blood cells. All these findings will come to know through the peripheral blood smears. Now, when we do a peripheral blood smear, okay, then we have to do the reticulocyte count. If there is normal or reduced reticulocyte count, and there will be increased reticulocyte count. These are the two findings which we will get. Okay, if there is normal or reduced reticulocyte count, then we have to go to check the serum iron levels, the different types of iron levels, that is serum iron, ferritin levels, okay, the total iron binding capacity. If these all are low, and obviously total iron binding capacity will be increased because iron is decreased, so the total iron binding capacity will be increased. Then we have to declare it as iron deficiency. Okay, see, now if there is normal or increased serum iron level, okay, with normal or reduced reticulocyte count, but then we have to go for hemoglobin electropoiesis, okay, or that is something called as HPLA, that is high performance liquid chromatography. We have to do this investigation. After doing this investigation, we have two results, that is, one is abnormal or normal. If the hemoglobin is normal, hemoglobin electropoiesis is normal, we will tell it as sideroblastic anemia, that is normal reticulocyte count, normal iron level, normal hemoglobin electropoiesis result leads to sideroblastic anemia. If there is anything abnormal in the hemoglobin, we know that it is called as haemoglobinopathies. Best example is your thalassemia. So, if the investigation shows normal reticulocyte count, we do two things. We have to look for the iron level in the body. If the iron level is low, we categorize it as iron deficiency. If iron level is normal, then we go for hemoglobinopathies. Sorry, hemoglobin electropoiesis. If it is abnormal, then declared as hemoglobinopathies. If it is normal, we will tell it as sideroblastic anemia. Okay, see, in certain diseases or if it is a chronic anemia, you will have low serum levels, okay, serum iron levels, but the ferritin levels and the total iron binding capacity will be generally normal. Then we will also check the erythrocyte sedimentation, that is the ESR, and CPR, that is CRP, that is C-reactive protein. If these two are elevated, we all know that these two are inflammatory markers, so we can categorize it as inflammatory diseases. If those inflammatory markers are normal, so we know that there is no inflammation in the body, but you have anemia, but you have normal reticulocyte count, but you have low serum iron levels, but your total iron binding capacity and ferritin levels are normal or they are elevated, and your inflammatory markers are absent or it is normal, then it is anemia of chronic diseases. It might be any renal, hepatic, or any other diseases. Now we will come to if there is increased reticulocyte in the body. We know that it is generally seen in cases of hemolysis or RBC lysis. So we know that it is present in cases of hemorrhage, sepsis and all. So we will go for hemoglobin HPLA, that is high performance liquid chromatography, or hemoglobin electrophoresis. So that will show you the result of what type of hemoglobinopathy it is present, or it is due to any sepsis, or it is due to any hemolysis. This flow chart or this results of classification is based on your peripheral smear. Okay, by the results of peripheral smear, after that we go through different series of investigation to come to certain conclusions. Okay, these type of conclusions, all these are approach to microcytic anemia. Okay, you can see it is iron deficiency, hemoglobinopathies, all these are microcytic anemias. Now coming to normocytic anemias, how we will find out or how we will decode which type of anemia, normocytic anemia it is. It is based on the reticulocyte count. If it is increased, then we know that it is due to hemolysis, that is positive test for hemolysis. If it is yes or no. If it is yes, it is obviously hemolytic anemia. If it is no, then you should think of where else the depletion of RBCs can happen. It can happen in hemorrhages or sepsis or recovery from nutritional disorders. Okay, this is what if the reticulocyte count is increased. Now, if the reticulocyte count is normal or reduced, we know where we will get low reticulocyte count. It is generally seen in infections like parvo diseases, red cell aplasia, congenital or acquired hypoplastic anemia, bone marrow infiltrations. Okay, these are the different. Now, how to decode it to a particular disease? Yes, so as usual, as what we did above, same we will go to look into the serum iron levels. Okay, if it is low, see here we did the same thing. Okay, normal or reduced reticulocyte count. We saw that it is due to, if it has low serum iron levels, we declare it as anemia of chronic diseases. The same thing we are doing here, or it might be sign of early iron deficiency. Okay, next we have, if the serum iron level is normal or high, then we have to go for bone marrow biopsy looking for any other malignancies, that is bone marrow infiltrative disorders. Okay, if it is normal, we have to screen for renal and hepatic endocrine diseases to find out any particular renal or hepatic chronic diseases leading to anemia, or else again bone marrow biopsy leading for your bone marrow diseases, infiltrative disorders like leukemia and all. Now, what is the other type of anemia? That is macrocytic anemia. So in peripheral smear we get macrocytes. The first investigation result showing macrocytic anemia is your peripheral smear. That is, macrocytes are present. If macrocytes are present, it is obviously your megaloblastic anemia. It might be due to your vitamin B12 or folic acid deficiency. Okay, then if they are not present, you have to again look for reticulocyte count. Okay, reticulocyte count. If the reticulocytes are increased or decreased. If increased, we know it is due to hemolysis and hemorrhages. If the reticulocytes are not decreased, then we have to look for chronic diseases like liver function test, thyroid function test. This is the chronic disorders leading to particular anemia of chronic diseases. Now, see, we all know that this was a tedious and a lengthy process. We cannot follow this cumbersome classification if we get a child. So I will show you a brief classification of anemia, okay, so that we can come into a particular conclusion instantaneously. See, if a child comes with anemia, we have to look for hepatosplenomegaly in the child. Okay, if yes, that is the hepatosplenomegaly is present or absent. Okay, if hepatosplenomegaly is absent, then we have to look for petechiae in the child. What I am showing you, it's a clinical approach. What we discussed earlier was the diagnostic approach. So if no splenomegaly or no hepatosplenomegaly and no petechiae, it is generally your nutritional disorders like iron deficiency, megaloblastic anemia, okay, or lead poisoning or chronic kidney disease. Okay, if petechiae are present, then we have to think of the first very important, this one is no splenomegaly with the petechiae in a child having anemia. You must remember a plastic anemia. Okay, the other classifications include bleeding disorders, coagulopathies, that is coagulation disorders, okay, and DIC, disseminated intravascular coagulation. Okay, so petechiae is present. If petechiae is present, these aplastic anemia, bleeding disorders, coagulation diseases, and DIC. So if hepatosplenomegaly is present, okay, then you have to look for lymphadenopathy in the child. Okay, we have to look for lymphadenopathy in the child. So if lymphadenopathy is present, or it might be absent. So if lymphadenopathy is absent, then you only have hepatosplenomegaly. So then it is generally a case of thalassemia, that is hemoglobinopathy disease, thalassemia or sickle cell anemia. All these are hemoglobinopathies. Here there will be increased destruction of the RBCs leading to splenomegaly and hepatosplenomegaly, but there will be absence of lymphadenopathy. If lymphadenopathy is positive along with hepatosplenomegaly, then you should think of malignancies. Malignancies such as leukemia. Okay, main thing this one. Or else you can also think of some infections and your bone marrow infiltrative disorders. So this is the clinical approach to a child coming with anemia. That is, if a child comes with anemia, you look for hepatosplenomegaly. If it is present, you look for lymphadenopathy. If lymphadenopathy is present, you have to think of malignancies like leukemia. If not, you should think of thalassemia and sickle cell anemia. And based on this clinical approach, you go for your what type of investigations you have to go through, and based on the investigation you go for a confirmatory diagnosis and start the child on the treatment. So if the hepatosplenomegaly is absent, you have to check for petechiae in the child. If there are no petechiae, it is generally your nutritional disorders, that is iron deficiency, megaloblastic, lead cell poisoning, chronic kidney disease. If petechiae are present, it is generally aplastic anemia. Main thing, hepatosplenomegaly, no hepatosplenomegaly with petechiae, you should go for aplastic anemia. Very, very important. If not, it is bleeding disorders, coagulopathy disorders, or something called as DIC, that is disseminated intravascular coagulation. So today, in short, we discussed what are the clinical features, general clinical features of a child coming with anemia, what is the clinical approach, and what is the diagnostic approach, that is investigational approach to a child. So if you are thorough with this clinical approach, then you are going to narrow down into very few diseases for which you can go for a particular investigation and lead to the confirmatory diagnosis. So we all know that what are the investigation modalities for microcytic, normocytic, and macrocytic anemias. So we all saw the different types of investigational approach for different types of anemia. Okay, thank you.